Welcome to the deep dive. Let's jump right in today with something that's, well, surprisingly common, but also incredibly serious. Abdominal aortic aneurysms.
That Rutherford.
Delays.
Right.
And get this, stats suggest maybe 4 to 7% of adults in Western countries have one. That's a, that's a lot of people.
It really is. But the critical thing, the really stark difference, is what happens if it ruptures.
Exactly. If you have a planned elective repair, the operative mortality is around, what, 3%?
Hmm.
Which is still surgery, but manageable.
Relatively low, yes. But if that AAA ruptures, the chances of surviving surgery suddenly plummet. We're talking 40, maybe even up to 90% mortality?
A world of difference. Those numbers alone just hit you. They tell you why this matters so much.
Absolutely. And look, medical information can be completely overwhelming, right? Like you're trying to drink from a fire hose sometimes.
Yeah, definitely.
So that's why we're doing this. We've gone through a really detailed source, a chapter called Abdominal Aortic Aneurysms Open Surgical Treatment, to pull out the key things you need to know.
Our mission, then, is to get a clear picture of open surgical repair, OAR, for these AAAs. Where does it stand today?
Exactly. We'll look at the techniques, why doctors choose it over other options, and sort of how it fits into the whole AAA treatment landscape, especially compared to the less invasive option, EVAR.
Okay, so let's start there. OAR versus EVAR. It wasn't always a choice, was it? For a long time, open surgery was basically it.
That's right. For decades, OAR was the gold standard, really the only established treatment. But then 1999 happened. The FDA approved the first endovascular aneurysm repair, or EVAR, devices.
And that changed everything.
It was a seismic shift. I mean, the appeal was obvious, right? Minimally invasive, you're talking faster recovery times.
Less time in the hospital.
And the initial data, the early studies, suggested lower operative mortality compared to the big open operation.
And it really caught on fast, didn't it? It felt like EVAR quickly became the main approach.
Oh, absolutely. The numbers back that up. If you look at, say, Medicare data between 2003 and 2013, OAR procedures dropped by a massive 76%. 76%.
Wow, yeah. And during that same time, EVAR volume nearly doubled.
Yeah.
And the technology kept getting better, too. More complex EVAR techniques came along.
Like fever.
Right, fenestrated EVAR, that's where they make custom holes in the graft for the kidney or gut arteries. And Shea EVAR, chimney EVAR, which uses little parallel stents, all designed to treat tougher aneurysms, closer to those vital branches, but still minimally invasively.
So with all this fancy EVAR tech, you'd think open surgery would be, I don't know, fading away? Maybe just for the really rare cases?
You might think that, but here's where it gets really interesting. As EVAR took over the more straightforward cases, OAR actually became the procedure reserved for the more complex situations.
Ah, okay, so the harder ones.
Exactly. The ones with really challenging anatomy or where EVAR just wasn't suitable for some reason. And that meant the open surgery surgeons were doing became, on average, more difficult.
How so? Well, needing to clamp the aorta higher up, above the renal artery suprarenal clamping, or even higher, near the celiac artery, became much more common, maybe in 30 to 50% of open cases now.
And clamping higher up is riskier, right? For the kidneys, the gut.
Definitely adds complexity and potential risk, yes. But here's the surprising part. Despite tackling these tougher cases, the overall mortality rates for OAR haven't really gone up.
That is surprising. It speaks volumes about surgical skill and care, I guess.
It really does. And what's more, some studies started to show that in certain complex scenarios, OAR might perform just as well, or maybe even better than the advanced EVAR techniques.
Like what?
Well, one meta-analysis looked at elective OAR versus FEVAR for juxtarenal AAAs, those right up against the kidney arteries. Perioperative mortality was similar, but the FEVAR patients needed more follow-up procedures and had more kidney problems later on.
So potential long-term trade-offs with the less invasive approach there.
Potentially, yes. And another study, a propensity-matched one looking at complex AAAs, actually found higher morbidity and mortality with FEVAR compared to OA.
So open repair definitely still has a crucial role. It's not just a backup plan.
Not at all. It reinforces that OAR remains a really valuable and sometimes superior option in the right circumstances. Of course, the whole long-term comparison is still evolving, with ongoing research and trial results.
Okay, so EVAR does a lot, clearly, but OAR is far from obsolete. Let's really try to nail down why a surgeon would opt for open repair today. What are the specific reasons, the indications?
Sure. We can kind of group them. There are patient factors, anatomical challenges, the shape and size of the aneurysm itself, issues from previous treatments, certain specific types of aneurysms, genetic conditions, and even sometimes patient compliance issues.
Okay, let's unpack those. Start with the patient themselves. What about the person makes OAR a better fit?
Well, age is a big one. Younger patients, people with a long life expectancy who are otherwise pretty healthy. OAR might offer better long-term durability.
Because the repair might last longer.
Potentially, yes. And there's also this growing awareness about radiation. EVAR needs a lot of CT scans for follow-up year after year. For a younger person, that cumulative radiation dose over decades is something to consider.
That makes sense.
And then there's patient preference. If someone understands the pros and cons and they strongly prefer open surgery, well, that carries weight, assuming the risks aren't prohibitive for them.
Right. Now, what about the aneurysm's anatomy? When does its shape or location point towards open repair?
This is a major category. If the aneurysm's anatomy is just unfavorable for EVAR or FEVAR, maybe the bit of normal aorta above the aneurysm where the graft seals is too short, too wide, too angled. Basically, if it falls outside the instructions for use, the IFU, for the available devices.
So the plumbing doesn't fit the parts available.
Kind of, yeah.
Yeah.
Another big one is needing to keep the inferior mesenteric artery, the IMA, open.
The blood supply to the colon.
Part of it, yes. If that artery is really large and crucial because other gut arteries are blocked, or if the patient's had prior colon surgery, or maybe blockages in the pelvic arteries, you might need OAR to specifically reimplant that IMA.
Okay. What else anatomically?
Tricky kidney anatomy, like a horseshoe kidney or an ectopic kidney, multiple renal arteries, those can make EVAR really challenging. Also, if doing EVAR would mean blocking blood flow to both hypogastric arteries, the main pelvic arteries, OAR might be better to preserve pelvic circulation.
That's right.
And symptomatic or ruptured aneurysms right up by the kidneys, juxtarenal ones. If you don't have time to wait weeks for a custom FEVAR device, OAR is often the necessary approach.
Right. Time is critical then.
Absolutely. And then finally, just simple access problems. If the patient's arteries in the legs or pelvis are too narrow, too twisty, too blocked up to get the EVAR device through safely, open surgery becomes the only route.
So basically, OAR steps in when EVAR hits an anatomical roadblock. What about people who've already had aortic surgery or an EVA?
Yeah, that's another key group. Sometimes a previous EVAR fails and needs converting to open repair. This could be due to an infection of the graft, or maybe what we call device failure endoleaks that won't seal the device moving.
Leaks around the graft.
Right, type 1 or 3 endoleaks, or even type 2 endoleaks, the ones from back bleeding branches, if they cause the aneurysm sac to keep growing despite attempts to fix them endovascularly. And sometimes even a prior open repair can fail and need reoperation.
Okay. Are there specific kinds of aneurysms where OAR is usually the first choice?
Yes, definitely. Things like inflammatory AAAs, where there's a thick inflammatory rind around the aorta, they can be very difficult to treat endovascularly.
Because of the inflammation.
Yeah, and the scarring. Also, mycotic aneurysms, infected ones, you generally need to cut out all the infected tissue, which means open surgery.
Makes sense.
And aortoenteric fistulas, a connection between the aorta and the bowel. That's almost always an open surgical emergency, though sometimes EVAR can be a temporary bridge.
You also mentioned genetic conditions earlier. How do they play in?
This is really important. For patients with certain connective tissue disorders, Marfan syndrome, vascular Ehlers-Danlos, Loeys-Dietz, and a few others, the whole aorta tends to be weaker.
So just fixing the aneurysm isn't enough?
Often not. The concern is that other parts of the aorta could dilate later, so OAR is generally preferred because the surgeon can replace a longer segment of the aorta if needed, really reinforce things, and avoid techniques used in EVAR that might not hold up as well long-term in those weakened tissues.
Right. A more robust, extensive repair.
Exactly. And the last factor you mentioned was compliance.
Yeah, follow-up. How does that factor in?
Well, EVAR requires lifelong surveillance. Regular imaging, usually CT scans to check for leaks, migration, make sure everything is okay.
Which involves appointments, scans.
Right. And if a patient is thought to be unlikely, for whatever reason, to stick to that strict follow-up schedule. And if their surgical risk for OAR isn't too high, then open repair might actually be the more reliable long-term option because it generally needs less intensive monitoring afterwards.
Interesting point. Okay, so that gives us a really solid picture of when OAR comes into play. Now let's shift to the how. What happens before the operation? The planning, the assessment.
This part is absolutely crucial because open aortic surgery puts a big strain on the body. The heart, lungs, kidneys all take a hit from the clamping. Meticulous patient selection and preparation are key.
Making sure the patient is fit enough for the operation.
Precisely. A thorough workup of their cardiac function, their pulmonary function, their kidney function is essential. We need to know if they can tolerate the stress of the procedure.
And you mentioned frailty earlier.
Yes, we're increasingly using frailty assessments. Tools like the MFI score, the Modified Frailty Index, can help predict post-operative complications and recovery. It helps guide that shared decision-making process between OAR, EVAR, or maybe even deciding that no intervention is the safest path for a very frail individual.
So things like nutrition, muscle mass, they matter too.
They can, yes. Sarcopenia, low muscle mass, can be an indicator of higher risk. It's all part of building a complete picture of the patient's resilience.
And imaging. Getting that roadmap.
Absolutely vital. CTA, computed tomography angiography, is the gold standard. It gives us incredible detail.
What kind of detail?
Everything. The exact size and extent of the aneurysm, its shape, how much calcium or clot is inside, whether it involves the visceral arteries, any anatomical variations. All the information the surgeon needs to plan the approach, figure out where to clamp, what kind of graft to use.
And if someone can have a CTA, maybe kidney problems or allergies.
MRA, magnetic resonance angiography, is an alternative, but it's generally not as good at showing calcification, which can be important for planning the clamping and sewing.
Okay, roadmap acquired. Now we're in the operating room. I know there are a couple of main ways surgeons approach the aorta for open repair.
That's right. The two main routes are the transperitoneal approach and the retroperitoneal approach.
Through the belly versus around the back.
Essentially, yes. The choice often depends on the surgeon's preference and experience, but also on patient factors and the specifics of the aneurysm.
Let's start with transperitoneal. What does that involve?
That's the classic midline incision, straight down the abdomen. Sometimes it needs to be extended upwards, maybe towards the chest, if you need really good access, high up near the visceral arteries.
So big incision.
It can be, yes. The key is getting good exposure. The intestines are carefully moved aside, usually packed away in moist towels, and the surgeon dissects down through the tissues overlying the aorta.
What are the advantages of going this way?
It gives pretty rapid access, especially to the aorta below the kidneys, the infrarenal aorta. It's very versatile, allowing good access to the iliac arteries down in the pelvis and also to the visceral branches if needed. It's often the preferred approach in emergencies, like a rupture.
Because it's faster.
Generally faster to get control of the aorta, yes. And sometimes, for really high access, surgeons use a technique called medial visceral rotation, where they swing the left-sided organs over to the right to expose the aorta higher up.
Okay. Now, what about the other way, the retroperitoneal approach? How's that different?
For this one, the patient is positioned on their side, usually the right side down. The incision is made on the flank, typically the left flank, often between the ribs and the hip bone.
So coming in from the side.
Exactly. The surgeon goes behind the peritoneum, the sac that holds the abdominal organs, without actually entering the main abdominal cavity. The abdominal wall muscles are separated, and that peritoneal sac is gently pushed forward.
What's the benefit of that?
It provides excellent exposure of the aorta higher up, around the renal and visceral arteries, and can even extend up into the chest if needed for thoracoabdominal aneurysms.
When might this be preferred?
It can be really good for patients who have had lots of previous abdominal surgery, making a midline approach difficult due to scar tissue. Also potentially beneficial for very obese patients or those with significant heart or lung problems, as it might cause less physiological disturbance.
Less stress on the body.
Potentially, yes. Some proponents argue it leads to less fluid shifts, fewer pulmonary issues, less ileus where the bowels slow down, maybe shorter hospital stays, faster recovery, maybe even lower cost.
But is that proven?
Well, the evidence is a bit mixed. Some studies support those benefits, others haven't shown a huge difference. Interestingly, the Society for Vascular Surgery guidelines do suggest it might be preferred for intact infrarenal AAAs.
Are there any downsides to the retroperitoneal approach?
The main potential limitations are that accessing the very far end of the right iliac artery can sometimes be tricky from the left side, and visualizing the origin of the right renal artery can also be a bit more challenging. And one recent study did suggest maybe a higher rate of late reinterventions or readmissions with the transabdominal approach, so the debate continues.
So pros and cons to both, depends on the situation. Okay, once the surgeon have access, what are the key principles during the actual repair?
A few really critical things. Managing the aortic cross-clamp is paramount. Clamping the aorta dramatically changes hemodynamics, blood pressure, heart
And
workload.
stopping the flow.
Exactly. So there needs to be constant, close communication between the surgeon and the anesthesiologist to manage blood pressure, fluids, medications, making sure vital organs are perfused as well as possible.
Protecting the organs during clamping. You mentioned kidneys earlier.
Yes, intraoperative renal protection is a big focus, especially with clamping above the renal arteries. Various things have been tried, diuretics like furosemide, mannitol, dopamine, but honestly, none have definitively proven to make a huge difference in large studies.
So what does help?
The single most important factor is minimizing the cross-clamp time, just getting the sewing done efficiently and safely. For more complex repairs, like juxtarenal or thoracoabdominal aneurysms where clamp times are longer, surgeons often use cold crystalloid perfusion, flushing the kidneys with cold solution to protect them during the clamping period.
Makes sense. Slow down the metabolism.
Exactly. And then there's the reconstruction itself.
Replacing the diseased segment.
Right. The basic steps involve clamping proximally and distally, opening the aneurysm sac lengthwise, cleaning out all the thrombus and debris inside.
Getting rid of the clot.
Yes. Then carefully sewing in the prosthetic graft, usually Dacron or PTFE using strong sutures. This could be a straight tube graft if only the aorta is involved, or a bifurcated Y-shaped graft if the aneurysm extends into the iliac arteries.
Creating the new pathway for blood.
Precisely. Making sure the connections, the anastomoses, are secure and leak-proof. And then typically the old aneurysm wall, the sac, is closed over the new graft, kind of wrapping it for extra protection and separation from the bowel.
That sounds incredibly precise. It's major surgery, though. What are some of the potential complications that patients and doctors need to watch out for afterwards?
Yeah, despite all the advances, complications can happen. They can affect almost any organ system. Myocardial ischemia or heart attack is a risk because of the stress on the heart.
From the clamping and blood pressure swings.
Exactly. Respiratory complications like pneumonia or difficulty weaning from the ventilator can occur, especially after long operations or with higher clamping. Acute kidney injury, AKI, is a significant concern.
Especially with that suprarenal clamping.
Right. Related to clamp level, clamp duration, sometimes showers of small emboli. And ischemia, lack of blood flow, can affect other areas too. Visceral ischemia affecting the intestines, or specifically colonic ischemia.
Ischemia of the colon. You mentioned that being maybe more common with OAR.
It can be, yes, often related to having to ligate or tie off the IMA if collateral circulation isn't sufficient. Other factors play a role too: injury to collateral vessels, low flow states, issues with pelvic perfusion.
How does that show up?
Symptoms can range from bloody diarrhea and abdominal pain to fever, sepsis. It's serious. Diagnosis often involves sigmoidoscopy or colonoscopy to look directly at the colon lining, maybe a CT scan. Treatment involves fluids, antibiotics, bowel rest, and sometimes surgery if there's perforation or necrosis.
Okay. What about other types of ischemia?
Lower extremity ischemia, problems with blood flow to the legs, can happen due to technical issues with the graft or emboli going down the legs. And then there's spinal cord ischemia.
That sounds particularly frightening. How common is that?
Thankfully, it's rare after standard infrarenal AAA repair, maybe less than 1%. But the risk increases significantly with more extensive repairs, especially those involving the thoracic aorta, like extent foravis thoracoabdominal aneurysms.
Why higher up?
Because important arteries supplying the spinal cord, like the artery of Adamkiewicz, often arise from the aorta in that region. So managing blood flow, minimizing clamp time, sometimes reimplanting critical intercostal arteries, it's all crucial for prevention. The consequences can range from temporary weakness to permanent paralysis.
A devastating complication, even if rare. Okay, so the patient gets through the surgery, recovers, goes home. Is that it? Or is there ongoing monitoring needed after OAR?
There is surveillance, yes, though typically less intensive than after EVAR. You still want to monitor the repair long term.
Checking for what?
Leak complications like pseudoaneurysm formation at the suture lines, graft limb issues, or degeneration of the aorta nearby. CTA is generally the preferred imaging for this, giving a good look at the graft and the surrounding aorta. Ultrasound can track the size of the old aneurysm sac, which should shrink over time.
How often?
The current SVS guidelines suggest a baseline CTA within about 6 months post-op, and then maybe follow-up imaging every 5 years or so, assuming everything looks stable.
And you mentioned checking the chest, too.
Yeah, there's a recommendation for a one-time chest CTA at some point because patients with AAAs have a significantly higher risk of developing thoracic aortic aneurysms later on. It's worth screening for.
Good point. Now, we've mostly talked about standard OAR.
Yeah.
Are there special situations that need a different playbook?
Yes, several important ones. Open conversion of a prior EVAR is becoming more common as more EVARs are done, sometimes outside strict guidelines and as they reach their lifespan.
Fixing a failed EVAR with open surgery.
Exactly. It can be really challenging surgery, especially getting the old endograft out if it's firmly incorporated or has anchoring hooks, particularly suprarenal ones. Emergency conversions for rupture or infection have much higher risks than planned elective conversions.
Right else.
Infected AAAs or mycotic aneurysms, we touched on those. They require aggressive treatment antibiotics, drainage of any abscesses, followed by surgery to completely remove the infected aortic tissue and surrounding inflammation, and then reestablishing blood flow.
How do they reconstruct?
Ideally, using infection-resistant conduits. Sometimes special grafts soaked in antibiotics or even using the patient's own veins, like the femoral vein, to create a new aorta, a neo-aortoiliac system or NAI's procedure. In situ repair is generally preferred if possible.
Complex stuff. Any other potential types?
Inflammatory AAAs, IA, AAAs, these are distinct. They have this thick, white, fibrous inflammatory wall, often present with back or abdominal pain, elevated inflammatory markers.
Makes surgery harder.
Definitely. There can be dense adhesions, especially to the duodenum, the first part of the small bowel, which sits right over the aorta. Dissection can be tricky, and there's a higher risk of injuring adjacent structures, like the ureters.
How are they managed?
Smaller ones might be managed medically first, sometimes with steroids, especially if it's related to a condition called IgG4-related disease. But the size threshold for repair is generally the same as for regular AAAs. There's debate about OAR versus EVAR, but retroperitoneal OAR is often favored to avoid that difficult dissection around the duodenum. Careful technique is key.
It really sounds like OAR requires a huge amount of judgment and adaptability.
Absolutely. And the chapter we used as a source actually includes a decision-making algorithm, sort of a flow chart, trying to integrate patient risk factors and aneurysm characteristics to help guide that choice between open and endovascular repair. It's complex.
This has been an incredibly informative deep dive. If you had to boil it down, what are the absolute key takeaways for our listeners about open surgical repair today?
I think the main message is OAR is definitely not a relic of the past. While EVAR is fantastic for many patients, open repair remains absolutely essential. It's the critical option for anatomically complex aneurysms for certain patient groups when EVAR isn't feasible or when EVAR has failed.
And success hinges on.
It really hinges on careful patient selection, meticulous preoperative planning, precise surgical technique, whether transperitoneal or retroperitoneal, and vigilant management of potential complications. It's still a cornerstone of vascular surgery.
So as we wrap up, here's something to chew on. We see technology racing ahead in both open and endovascular techniques. Surgeons are tackling ever more complex aortic disease. Looking forward, how do you think the balance might shift? How will we decide the optimal strategy for each individual within AAA in the coming years? It's that constant interplay, isn't it, between invasiveness, durability, patient factors. Definitely something to keep thinking about.
It is indeed. Hopefully, this discussion has given you a much clearer understanding of the vital role open surgery continues to play. As always, keep learning, stay curious, and consult with healthcare professionals for any personal medical advice.